All right, our last section, our last slide set for the day. We're going to go through some gastropath. Some of these pathologies you've heard of before, some of them you might not be as familiar with. I'm going to try to do my best to synthesize like what you need to know, just like what I did with cardiopath. There was a great question in the break about some of the pathology I've seen, I feel really comfortable with, and some I've never even heard of before. What do I do with that? At this point, name recognition can be key. So at least reading the disease and knowing a definition of it, like a Merck definition, a basic, simple definition, that could be great. If you're like, I cannot learn new things right now, fine. Excel on the ones that you know and ignore the ones you've never heard of before. Either strategy is okay at this point, but you're not going to know everything, all of the conditions, all of the stuff for this test. It's just impossible. So I would say either strategy for things you've never heard of before, either getting at least a definition. That's why I would do at least like, okay, I know kind of what this is, this location or this thing, or just lean into the ones you already know and know those better, right? Okay. So for our gastropath, there's a lot of questions in our gastro section regarding like pain patterns, referred pain, where pain's located, and that can help with answering a lot of your different questions. So understanding these are referred pain patterns. So knowing like if you're having stomach pain, where they could refer to gallbladder pain, yada, yada. I actually see these asked about or help inform your diagnostic or your path question decisions more in the gastro section. So it's not a bad idea to look through and at least kind of have some recognition of these referred pain patterns. Some important ones, obviously, I mean, stomach, that one's relatively easy. I would say gallbladder, because you can go to that right scapula, that one has a point of interest. And then Murphy's, obviously, McBurney's in the appendix area. There's any other interesting ones? Your costovertebral, your CVA place for your kidneys. Those would probably be the most interesting, I would say. Yeah, those would be the most interesting. So when we're looking here, there are some things that can cause chest pain. So kind of being able to separate certain conditions and be able to put your brain into the mindset of test takers could be helpful if chest pain is a part of your condition or case. So esophageal spasms can look like MIs or anginas. Gastritis or esophagitis, you're thinking of your burning, obviously anxiety or hyperventilation we have to have on this category. Acute MI, consider jaw, diaphoresis, left arm pain, or MSK, your costochondritis. They're going to give you your classic picture. They're not going to give you a picture that doesn't meet the classic characteristics of the condition. So if they give you an MI, they're going to give you left-sided jaw pain, arm pain, neck pain, like the squeezing, elephant sitting on your chest. That's what they're going to present you with for a lot of these pathologies, regardless of where they're at. So you will get gastritis as burning pain. You will get those associations. So some other funky gut conditions that we don't talk about as much. Achalasia. It's a motility disorder of your esophagus. It's secondary to your loss of neurons from the mesenteric plexus. So again, mesenteric meaning it's in the mesentery, neuron loss. So the actual cell body loss. Your lower esophageal sphincter, your LES, will fail to relax when you swallow. And you'll see an increased LES pressure with achalasia. And so you're having trouble essentially getting things down your esophagus, your tube. On other things, you can see esophageal spasm, different than achalasia. Sometimes this could be with drinking cold liquids that can make the dysphagia, that swallowing process, worse. And in this, you can also see food getting caught in the esophagus. Esophageal reflux, another esophageal condition. We know this one well. Our, acid reflux component. I'm not going to skip that. And then we're going to move down further because these are more fun ones. I'd say of the esophagus, achalasia. That would be the one I would put to memory, put to your brain. For your central or kind of your celiac-based pain, acute gastritis is a good one. Acute pancreatitis is also a good one. These two conditions in kind of the centralized location are asked about more commonly. In your left region, your hypochondrium, pancreatitis as well. Gastric ulcer, not so much. Spleen, really only in association with mononucleosis. When I see spleen rupture, splenic rupture questions, or in association with knowing its anatomy, knowing what blood vessel feeds it. So thinking about our ulcerative diseases, peptic ulcer disease, PUD is great test questions. We can pull in H. pylori. We can talk about different types of cells in the stomach that line the stomach and who secretes what. So typically, if we're talking about peptic ulcer disease, duodenal ulcers are more common than gastric ulcers, but both can occur. In gastric ulcers, H. pylori is associated with almost all cases. NSAIDs are also associated, smoking, acid reflux, but really make that association with H. pylori. It's typically in the lesser curvature, so the upper portion of the stomach. If it's in the greater curvature, you're going to see an increased risk for a complication of cancer. Perf and bleeding are your most common complications, and it's going to be worse with food, the pain. Worse with food, burning post-eating. Your duodenal ulcers are better with eating, right? So that makes sense physiologically. If you have an ulcer in your stomach and you eat food, your stomach's going to secrete what? Acid. That's going to way worse than an open cut, right? An open wound. Versus your duodenal ulcer, when your stomach's secreting acid, your duodenum is having a little bit of a break, right? Because nothing's moving into that when you're actually actively digesting food while eating. It's after you've kind of actively digested the food, a couple hours after eating, that's when things move from the stomach into the small intestine. And that's when the duodenum is really having its issue. That's when you'll feel the pain. So with duodenal ulcer, it's better with eating, more common in males than females, but can occur in both. And H. pylori is associated with 90% of cases. So again, H. pylori association with both. Duodenal ulcers also have an interesting cancer association. So gastric ulcers with gastric cancer, duodenal ulcers with multiple endocrine neoplasia. How common is that? Not super duper common. So I wouldn't necessarily jump over remembering it, but that is its more common cancer association if we wanted to make one. So gastric cancer is adenocarcinoma. Oh yeah, please. Yeah, absolutely. When it's in there, yeah, so bicarb is being released, but bicarb actually is more released in response to acidic chyme once the food moves from the stomach to the small intestine. So there is maybe some bicarb released also when food enters the stomach, when that distension happens, because there will be some like acid leakage into the small intestine when that occurs. And that can kind of neutralize things, but really it's the pain association or the feeling better with eating is because at that point, your pyloric sphincter is closed because the stomach's doing churning. So you're really not letting anything flow through right when you've ate food. Does that help? Awesome. Thank you. Good question. So gastric cancer, adenocarcinoma. So we're in our conversation. What is adenocarcinoma? What tissue type? Glandular. And what do we have a ton of in our stomach? Glands, right? All those cells that secrete stuff, glands. They secrete it into a gland. So gastric cancer is a cancer of our glands, right? Adenocarcinoma is almost always the cause. The chances of getting stomach cancer is higher if they've had H. pylori, if they're older, if they're male, if they smoke, or if they have a lot of dry salted foods, or essentially have a diet that is going to be sad or increase your risk of GERD because of the increased risk of H. pylori or ulceration. So those are your gastric cancer risks. I think the most common piece that they ask about is the adenocarcinoma. So being able to label it as the appropriate cell cancer type. Symptoms, these are your classic like cancer symptoms that you can see with some GI ones thrown in there. I wouldn't worry about committing those to memory. So we'll move on. Pancreatitis, there's so many etiologies, but I want you to remember it can be idiopathic, it can be associated with alcohol, it can be associated with gallstones, and it can be associated with hypertriglyceridemia, high triglycerides. So those are the actual 4 etiologies I want you to remember: idiopathic, high triglycerides, gallstones, and alcohol for pancreatitis. Your classic symptom is epigastric pain that bores through all the way to the back. That's only about 50% of people. It's better with sitting up or in the fetal position. It's worse with movement. I was going to give you a homeopathy person here. Smoking and alcohol. Smoking would be the worst one. So that would be the correct answer or the better answer. Both are correct. Thanks, Jocelyn. So for your pancreatitis, they're not going to ask you about this stuff here, but etiology is the common thing that I see asked. So idiopathic, alcohol, gallstones, hypertriglyceridemia. Pancreatic cancer, adenocarcinoma. So again, a glandular cancer, because pancreas is primarily a gland. This is specifically affecting the exocrine pancreas, right? The pancreas does have endocrine function as well. It's going to arise from the duct cells most of the time, almost all the time, 9 times out of 10 from the acinar cells. Most of them occur in the head of the gland. So for like location, for cancer type, adenocarcinoma, duct cells, head of the gland. Those would be your like best high yield for pancreatic cancer. If it spreads, it's going to go to lymph node first, and then lymph flow, and then from lymph flow, it'll spread to other organs. But it's going to, if it metastasizes, it's going to typically go to lymph node. It could go to peritoneum, but that's more rare. So I would remember pancreatic cancer, adenocarcinoma, duct cells, and the head of the gland. That's what I would associate with those. I don't care about diagnosis. I have some of this on here, partially because I also do some crossover for NPLEX too. So I have some diagnostics on here. Also, sometimes it can be helpful because you just had gastro. So if that helps you associate things, great, but you don't need diagnostics for this test. So our right hypochondrium, right upper quadrants, we need to remember our cholecystitis or cholelithiasis. That's our big one that we haven't discussed in that upper stomach region. So our cholelithiasis, remember, this is gallbladder stones, but not necessarily inflammation. Murphy's sign could be present. You could see leukocytosis, bilirubin, whatever. Essentially, it's just stones in the gallbladder, right? It's not necessarily inflamed. Nothing's blocked. We're just seeing stones. When we get cholecystitis, this is the inflammation of the gallbladder wall, most of the time associated with stones, but it doesn't always have to be, right? So a lot of these great questions, they'll ask you, like, is cholecystitis always associated with cholelithiasis, right? The always, the all, the nevers. Most of the time, if they give you an answer or a question that's always all or never, those are going to be wrong because there is enough variation in the body, 5% variation, that's not always, right? So anytime you see that, that could be an answer you eliminate. So it's probably not correct. It's probably not true. But almost always, that's fine, right? Almost never, mostly never, mostly not. Those are okay if they give you a quantifier. So those are kind of some of those test question things they can do. But the majority of people that have cholecystitis will have cholelithiasis. So inflammation with stones. Bilirubin would be kind of your cellular component or your biochemical component that you could connect it to, because you would be looking at total bilirubin and indirect bilirubin to differentiate potentially. Indirect or unconjugated bilirubin is more associated with Gilbert syndrome. Okay, scary biochem picture. We already did this yesterday. You don't need to worry about it again. This is a reminder that biochemistry never leaves us, okay? It's always related. I'm sorry, I know. Visible, audible sigh, I apologize. Okay, all right, a couple clinical pearls. This is all the way back from Dr. Chamberlain, if any of you ever had him. Unconjugated hyperbilirubinemia, think of hemolysis or Gilbert syndrome. So if they say anything about unconjugated, lots of bilirubin, think hemolysis, destruction of red blood cells, or Gilbert syndrome. That should be your association. That should be enough to get you there for those questions. Conjugated, you're thinking hepatocellular disease, biliary obstruction, so you could think of stone blockage. Those would probably be your biggest pieces for if they give you information about bilirubin. The only time I see them doing that is really when they're trying to draw you down Gilbert. So unconjugated Gilbert, conjugated, think of either liver or true gallbladder pathology, like a gallstone blockage. All right, our hepatitis. So we have our acute and our chronic hepatitis. Hepatitis A and E are our acutes. B, C, and D's are our chronics. So hepatitis A and E are fecal oral transmission. They have longer incubation periods. Typically, you aren't seeing hepatitis E in the US, although you can now. I mean, this is, you definitely could. But really, hepatitis A and E, typically self-resolving. When they get scary is in pregnant women. So in pregnancy, that's when you can see more fatality, more death, especially hepatitis E. Hepatitis B, C, and D are your chronic hepatitis. So all of them can be spread via blood or sexual transmission. We often think of our hepatitis C also as IV drug use, incarceration, like those type of pieces or those type of risks. Insidious onset, so symptoms, you may be completely asymptomatic, but hepatitis B associated with primary hepatocellular carcinoma as well as cirrhosis, hep C associated with hepatocellular carcinoma as well. Kicker here is which ones are most common where? Hep B, more common globally, hep C, more common in the US. So if they ask you, we have that test question, right? What's the most common chronic hepatitis in the United States or something? Hepatitis C would be your best answer. If it was global, hepatitis B would be your best answer. Okay. Part of that, we have vaccination for hep B, and most people in the United States are getting vaccinated for hepatitis B. Hepatitis D, you need to have co-infection with hep B always. So that's where hep D will come up. It can be deadly. This co-infection is deadly because it increases your risk for cancer. And we're seeing a primary hepatocellular carcinoma. So what's a carcinoma? What cell type? Epithelial tissue. Yeah, epithelial tissue. So carcinoma, epithelial tissue of the primary cell type is hepatocellular. So hepatocellular is telling you where the cells are in the liver, and it's telling you the cell type that's affected, the cell lineage, which is epithelial tissue. So if you know these terms, you can actually know a lot about the cancer because you can say, okay, what's epithelial tissue? What typically is involved in epithelial tissue versus glands versus, what was the other one? Connective tissue. It's really helpful. Okay. What do you need to know in these diagnostic components? Really, I would not worry about a lot of these serum diagnostic values because this is not a diagnostic exam, right? Transmission, sure. Chronic progression, great. Diagnostics, don't really have to worry about them as much. You really could answer most of your questions by understanding the difference between IgM and IgG. IgM is first on the scene to any infection when we're talking about immunoglobulins, antibodies. IgG will come next, come later as a response to something intracellular. So if you're seeing IgM, that probably means active infection. IgG could be active or previous infection or exposure via a vaccine. So some type of exposure. We don't know if it's active or previous, prior. That would really be the only antigen questions you would probably get on this test. Yes? Questions regarding shouldn't be in regards to type, could be in regards to immune response. So when I see vaccine questions being asked, it's more like immuno question based. So how would the body respond? What type of antibody would they form first or maybe second? What is the purpose immunologically of a vaccine? Those kind of questions. If there is a question that seems like it's treatment based or it's asking like what type of vaccine, that's a pharm question and shouldn't be on NPLEX 1. So it'll likely get tossed if it sneaks in there, which does happen. There was at least like 2 or 3 pharm questions on my NPLEX 1 test, and those they get thrown out. If they do end up on the exam, they won't actually represent your score. So hep C, again, we already kind of talked about this. Chronic. These are some of the serologic markers. Don't lean into those too much. Okay, cirrhosis. So we've talked a lot. When I came in, we talked about actual pathology of liver. If you were in gastro, we talked a lot about the progression of inflammation down to fibrosis, down to cirrhosis. So cirrhosis is just that end stage of that process. So we have fibrosis first, where we're lying down all those fibers, right? Those fibers, when we lie them down, eventually the functionality of the cells that we've lied the fibers between are going to become disrupted. And that's when we kind of get to that cirrhotic state. In this stage, like the liver will be firm because all those fibers are there, right? And those fibers are collagen and elastin, and that makes it feel like more of a firm organ. And I should say that really your cirrhosis questions will surround that tissue histology. So like, what's that progression? From like a hepatitis and inflammation to a fibrosis to a cirrhosis. That's really what they will ask you in regards to that. They also could ask like, risk factors for cirrhosis, which there's many, right? We could pull from alcoholic hepatitis. We could pull from our chronic hepatitis. So there's lots of places that we could pull. We could even pull from hemochromatosis, right? All of those pieces. NASH and NAFLD, yeah, absolutely. NASH and NAFLD, I see asked about, not differentiated often on NPLEX exams. So you could probably lump them together as both your fatty hepatitis, your fatty liver diseases. When I see them discussed, it's more in regards to cholesterol metabolism and lipid accumulation. That's when I see those ones asked about. Or asking about, can they lead to progression to fibrosis cirrhosis, which in theory they can over time. So that would be the two ways I could see a NASH or NAFLD entering into the conversation. Ascites, just think accumulation of fluid within the abdomen. It's like edema, but in your stomach. Abdominal mass or liver disease. Majority of our liver cancers are metastatic rather than primary. So the majority of liver cancers are metastatic. That means that they did not start in the liver, right? The primary place of cancer starting is where it initially started. If cancer moved somewhere, like let's say the cancer started in my kidney and then moved to my liver would be the secondary origin. It would not be primary, right? It would be my kidney that would be primary. So the majority of them are metastatic, not primary. Hepatocellular carcinoma is a primary liver cancer. It's associated with cirrhosis. So patients who have cirrhosis, their progression to hepatocellular carcinoma is likely. So any of your condition states where you get to a cirrhotic liver, that's your essentially complication you need to know and associate. Again, Hep B and C also big cause. Okay. Down low, we have our Crohn's, is that kind of the big one in the right lower quadrant to remember. You can also see some like referred pain, Meckel's diverticulum, a good like congenital one. But I think Crohn's we more think about in regards to true gut, not adding in repro on the lower right side, as well as appendicitis. I don't know why appendicitis isn't here. That's my first one. It's hilarious. Oh, I think maybe that's what this was in my brain at some point as abbreviation. Yeah, I don't know. Anyways, appendicitis, common McBurney's point. That would be like your main physical exam, clinical finding thing. I had an acronym at one point that was like patella. It was pain first, then anorexia, tenderness, and I forget the rest. I don't know if they're still teaching patella as a part of acute abdomen. No. Okay. I can find the acronym if you want me to, or the mnemonic. It wasn't super duper helpful. It was like the order in which symptoms presented in appendicitis. Pain first, anorexia second, tenderness third. I think that's kind of like the most important. And then from there, white blood cells and other things happen. Okay. Obviously, appendicitis is an acute surgical abdomen. Diverticulitis, think about this as the appendicitis on the left. So similar pain pattern. You're going to have acute pain, but a fully different etiology, right? Appendicitis is literally inflammation of your appendix versus diverticulitis and diverticulosis is related to this diverticula that gets essentially inflamed or infected. So diverticulum, plural diverticula, is just outpouching of the bowel. You can have that all over the place. Typically, your location is sigmoid and descending colon when it comes to diverticulum or diverticula. When you have diverticulosis, that's multiple diverticula, but it's not pathologic. So there's no inflammation, probably asymptomatic, and it's more associated with older age. Diverticulitis is when one or more than one of these diverticula get inflamed or infected. They don't have to be infected though, and that's why antibiotics, as we learned, aren't first line all the time. So again, left-sided appendicitis, pain, maybe a mass, often not. Okay. Kind of towards the back, really kidney pain is what I want you to lean into. This is a diagram that kind of shows you some of these referred pain sites here that are present. Hemorrhoids, the only question you'll be asked is relationship to the dentate line. So they'll ask you questions about internal hemorrhoids, dentate line, and neurologic sensation, right? Because above the dentate line, can we feel pain? No, below the dentate line, we can though, right? And so that's really where you get a nerve or vascular path question is in regards to internal external hemorrhoids. is in relationship to dentate line, anatomical structures, and neurovascular sensation. I don't really think abscesses are really that much to worry about. Typically, though, when in doubt in your gut, you're really, most of the time, we're going to get to gut gastroenteritis here in a second, but a lot of the bugs of the gut are or Enterococcus bugs, and there's a lot of gram-negative bugs in the gut. And so when in doubt, if you're trying to figure out what gut bug to choose from, and you have some like gram options, choosing a gram-negative is a good choice. It's not always going to lead you true, but it's a good option for dealing with the GI because the gram-negative tends to like to live in the gut. They tend to be more neuron there. E. coli and Proteus are both gram-negatives. Strep and Staph are gram-positives. Okay, fissures, fistulas, that's fine. Okay, colon cancer. Colons can develop anywhere. Polyps typically start first. Colorectal polyps can become cancerous. Here's your risk factors listed. There's many, many others too. I find their colon cancer symptom or colon cancer questions to be relatively straightforward. They're not going to test you on types of screening. They're not going to test you on specific like location of tumor. They're going to want you to know that's in the large intestine, but it can occur anywhere in the large intestine. So I find maybe they'll ask you about the cancer type, like the cell lineage involved. But that's probably it for colon cancer, colorectal cancer. So those ones are relatively straightforward. Where the gut, the GI questions get you is often in the gastroenteritises, which is why we're going to talk a little bit about etiologies of diarrhea. Woo. All right. So my favorite. All right. So when we look here, this little table we'll look at first, then we'll kind of go deeper into kind of a few of these different components. So this is showing the incubation time from when infected to when you'll show symptoms, what the diarrhea looks like. Are you vomiting? Are you having pain? Are you having a fever? So the first one are Staph aureus and Clostridium perfringens. Short incubation time, watery profuse diarrhea, vomiting, not much pain, no fever typically. It comes on too fast. Your body doesn't really have time to mount that response right away. Vibrio or E. coli, middle onset, also watery profuse diarrhea, moderate vomiting, mild pain. E. coli or Giardia takes longer, up to a week, could be variable, could be watery. Hemorrhagic E. coli, that's when you get into your bloody diarrhea, and C. diff, right? Bloody diarrhea, short onset. And then Salmonella, Campylobacter, Shigella, and E. coli that's enteroinvasive, meaning it invades the cells. Entamoeba, histolytica, these are also bloody. So the key here is bloody versus non-bloody. That can be a good separation point. And then from there, it's going to probably depend on what our source was, right? Where did we actually get exposed? That's going to key us in because a lot of the symptoms, the emesis, abdominal pain, fever, are kind of like not helpful when it comes to differentiating our etiologies. So first things first, cholera. From Vibrio cholera, it's going to feel like fullness first. You could see some like blood changes, massive, painless, watery purging. So your watery diarrhea. You're typically with your Vibrio cholera, like I said, it's in this category here. So you're seeing watery diarrhea, but not bloody diarrhea. So it's a key characteristic. Your E. coli enteritis, this is going to be water or fecal oral. And the enterotoxin of E. coli is what causes diarrhea, and it's typically not bloody unless if it's by your enterohemorrhagic strain, O157H7. That would be the one thing to memorize on probably this whole slide set, is to know the strain type of hemorrhagic E. coli, because that's asked about commonly. Other E. coli's, non-bloody diarrhea. That type of E. coli, bloody diarrhea. And that's the type that we're more concerned about in regards to causing more significant disease. E. coli that typically causes a UTI, not the hemorrhagic type, right? So different type of the bug, different strain of the bug. E. coli is a gram-negative rod. All right, so our food poisoning, we're gonna get into our food poisoning combos. So first are staph food poisoning. So oftentimes Staph aureus is the culprit, but we could clump together a lot of our different Staphylococcus, gram-positive cocci. They're going to see your cramps, your typical things. Your source is most of the time going to be meat-based foods, and symptoms can last for a couple days, up to a couple hours. Onset a couple hours, symptoms for a couple days. Gram-positive cocci. How will they ask these food poisoning questions? They'll often give maybe an exposure. So they might give you like what the person was eating, they might not. But they'll give you a component of like bloody or non-bloody diarrhea. So something like that. And then they'll give you a bunch of different bug names and a gram stain and a shape, typically. It's like probably 2 of those 4 options they'll give you. And then from there, you have to suss out which one is most likely the cause, recognizing that all of them will be things that can cause gastroenteritis. You're trying to choose the closest one for that case or for that question. And sometimes the question will present you new information that's not associated with said case. So read the question first. If you can answer it from that alone, do that. If you have to go up to the case, sure, that's fine. But try to answer it from the question alone if it gives you enough info. So botulinum toxin, Clostridium botulinum, this is a spore-forming bacteria. What that means is Clostridium species, they can form an endospore, which means that they can live on surfaces for a long, long period of time in almost a suspended animation state. It means that they're really good at infecting people because they can hang out for a while and then they'll start dividing and growing again when they're back in their happy, healthy environment. That's also Clostridium. There's 2 main endospore type forming bacteria, Clostridium being one of the main genus, not species. But lots of different nausea, vomiting, abdominal pain, cramps, etc. Canned foods is going to be your big association here, especially home canned inappropriately. You can have neuro symptoms later in phase. And typically with your botulinum toxin, what type of paralysis are you having? Flaccid paralysis versus for tetanus, what type of paralysis are you having? Spastic paralysis, right? So think about it, okay, when they're affecting, so with tetanus, we're having spastic paralysis, our sarcomeres can't let go. So we have our muscles contracted and it's not able to relax. In flaccid paralysis with botulinum, we're not able to contract. The muscle's essentially paralyzed, it's flaccid. So that's why I want you to differentiate the 2. They will often ask about those like flaccid versus spastic with botulinum and tetanus because it's such a good test question. I haven't seen floppy baby syndrome asked about before on NPLEX. It's clinically appropriate. I just haven't seen them talk about it on NPLEX before. So if you have that association, great, floppy baby syndrome, but I think probably less likely to come up on NPLEX exam. Cool picture though. I mean, not cool, but like really like if you see it, you're like, whoa. Yeah. Yeah. Correct. From binding to the nicotinic receptor. So you're unable to stimulate that neuromuscular junction to actually do a contraction. Yep. Versus tetanus, you're unable to actually release the myosin and actin head. So that contraction essentially is stuck together. You're unable to relax the sarcomere and go back to baseline. So you're contracted and stuck. Yeah. Good question. Awesome. So botulinum, home canned foods, flaccid paralysis. The gastroenteritis version won't necessarily cause neurologic symptoms right off the bat, right? It's going to be gut symptoms first. Clostridium perfringens, this is meat, usually meats that cook first, then kind of cool. Think about the meat that you made for the barbecue and then left out a little too long and got cold. Watery, profuse diarrhea is common. I think that will be my main. No, it's associated with some meat. Salmonella versus Shigella. So Salmonella, eggs or poultry. Shigella, poor hygiene. Rice. Gas gangrene, yes, yeah. Yes, perfringens, gas gangrene. I would be shocked if they ask about it, but they could. Yeah. Salmonella, eggs and poultry. Shigella, typically poor hygiene, person to person. Shigella is due to a Shiga toxin that typically causes symptoms, even up to seizures. You will typically have bloody diarrhea. Same with Salmonella, typically bloody diarrhea with both of these. Giardia, this would be water with animal feces contaminated, so contaminated water. More greasy stools associated, typically not as much associated with bloody stool. Also cryptosporidosis, rare, I would say, but it would be a contaminated water as well. Giardia, though, that would be the one I would know, the water one I would know. It's Giardia. Okay. That was my quick trip down that lane because we're going to talk about the bugs again when we do micro. So I don't want to spend too much time going through the grams and the positives and the negatives and the virulence factors because we're going to hit those again next week. Okay. My last piece of the puzzle, a little bit on Crohn's versus UC, because it's come to my attention that we might not have really learned how to differentiate that in a clear way. So I'm going to go through some things. So Crohn's versus ulcerative colitis, both irritable bowel diseases, both commonly tested on NPLEX. The site of origin, this is not 100%, right? So you can have them occurring anywhere, but if they forced you into a corner, terminal ileum would be more likely associated with Crohn's. Rectum is more likely associated with UC, but can they occur elsewhere in the bowel? Absolutely, right? Skip lesions are associated with Crohn's disease. So if you see skip lesions, think Crohn's. Typically, it's proximally contiguous, meaning after onset, it's going to be more likely to be a continuous ulceration or continuous association. That's the whole reason why skip lesions make it unique for Crohn's, because the lesions can skip spaces, but it doesn't mean it's continuous throughout the whole bowel. When it comes to thickness of inflammation, this is also an area where we can see it kind of go either direction. But if they make you sit in a corner, right? If I'm saying we're not able to say that that both could be both, Crohn's tends to be more transmural. UC tends to be more submucosal or mucosal. But can they both go through all the layers? Sure, they can. I'm just saying if we have to pick sides, okay? Symptoms, both could technically have bloody diarrhea, although it's more associated with UC. Complications, toxic megacolon is one that they like to just ask about in association with ulcerative colitis. So knowing that's a complication can be helpful versus fistulas, abscess, or obstruction with Crohn's. I wouldn't really worry. Oh, here, string sign versus lead pipe colon. Those would be other pathognomonic signs they could associate with Crohn's or UC, respectively. I wouldn't care about these. They both can increase risk. So I would say both increase. Skin manifestations, they can both cause erythema nodosum or polyderma gangrenosum. It's more rare in Crohn's, but both can have these. Both can have arthritis. Both could see ankylosing spondylitis. Both could see uveitis. Both could see fatty liver. Nephrolithiasis more associated with Crohn's, but I would say you really could see these complications in other areas, these extra manifestations in both conditions. But that's a great question that they could ask for, would be what's an extra manifestation of IBD? And then giving you some list of conditions. So knowing erythema nodosum, arthritis, uveitis, and fatty liver, those would probably serve you well. But for differentiation purposes, I think if you know skip lesions, string sign, and lead pipe, and you associate bloody diarrhea a little more with UC, that should get you through most of your IBD differentiation questions. But that will probably be on your test in some way, shape, or form. It's just too good to not. Okay. I think those are my main pieces of the puzzle here. Those are diagnostics, lactose intolerant, celiac sprue. One piece of celiac sprue that's come up recently a lot more is recognizing the vitamin association. It's a great biochem tie-in. So B12, folate, and iron are really your celiac sprue enteropathy vitamin deficiencies. We've seen that asked a decent amount of times because they all are absorbed from that small intestine. And then also the skin representation, dermatitis herpetiformis. I've seen them ask dermatitis herpetiformis, what's the etiology or association, and try to have you say herpes. And then they have celiac as an option. So please remember, dermatitis herpetiformis is associated with celiac sprue or celiac enteropathy. If they ask you that, you'll now know not to be pulled by the name. Dermatitis herpetiformis, it's literally a skin rash. It looks like little skin bumps that can be itchy and irritated, and it's associated with eating gluten or gluten consumption with someone who has celiac. It's like your skin representation of celiac disease. Not necessarily with that one. You can see it on arms, legs, and on torso. I think you're thinking of, it's not polyarteritis nodosum. We'll get to it next week. I was like, I'll look it up too in a sec, because it's gonna bug me. All right. Yeah. IBS, we've got, okay, great. Did it. What questions? Talk to me. Here's our list. Let's get the gut. Gut questions, gut path. What do we want to know? What do we need to know? We covered a lot of the big ones, okay? Let's see if there's any others that I think may come up that I would have you look at. Maybe look at Barrett's in regards to this tissue change that occurs and the location where you would see said tissue change. That's a histologic question. There's actually pathophysiology there. For congenitals, the only one I would really look into is Meckel's diverticulum. And then we're going to look at our gastroenteritis again when we talk about microbes next week. So we will revisit that discussion with microbes and kind of look at all of our potential options and how to differentiate each. So we will do that next week again. That's why I would do gut. Otherwise, you're golden. You know it all. Anything I can answer before the weekend? Okay. Yes. Fair. Please. Yes. Yes. Yeah. So in the past, yeah. Because so repro and integument, you don't get your second year skin. Yeah. Okay. So for repro path, the question was, we haven't had repro block yet. So how do I know what to focus on and study? I think starting with STDs are great because you can associate them with a bug, which is awesome. I would then move into, I am gonna do a lecture on it. So we will do some next week, but if I had to lean into a few now, menopause, perimenopause is an easy one for them to ask questions on. Endometriosis and PID, because that kind of ties into the STIs. They love asking about like all of these congenital, genetic, horrible conditions. So we'll look at them again. All the seals, because this is a great test question to confuse you. Hemato, hydro, spermato, varicocele. Breast cancer or fibroadenoma. So like knowing the difference between like these benign and malignant neoplasms of the breast, that would be the breast thing I would learn. BPH, prostatitis, sure. Of the ovaries, PCOS is really the only one that comes up. And then your cancers, so your CINs. That's really the only one. They don't like testing a lot about women's health. They test about men's health. It must be a men test writer. I don't know. Test about men's health a lot when it comes to that area. I would say if you start with STDs, you do PID, breast cancer, cervical cancer. That'll be a pretty good, and PCOS. That'd be a pretty good start. And then we'll relook at some of the annoying genetic ones and then like the seals of the men next week. Yeah, good question. Sorry, gentlemen on the call, if I offended you. Okay, awesome. All right. I will see you all next week. Thank you. I'll post these lectures later today.